Okay, so we're now going to turn to the Q&A portion of our event. We've got about 30 minutes for Q&A. You're welcome to address one of the particular panelists or to many of the guests here today. One advantage I have by being the facilitator here is I get to get the ball rolling with my own question. That's a real advantage. And this is really based on Darren and Joanna's panel and comments, and it goes to the heart of, kind of the big question here. What will it take to make a difference here in this epidemic? And it strikes me that, as you both spoke, that we have an information gap, right? You spoke about how the primary care docs are not as trained in addiction as they need to be. You also talked about kind of the separation between behavioral health and primary care, and have essentially two separate systems working jointly, but in some ways separately. You also talked about sharing information at the patient level is really not as easily done as it should be. And then I think you also talked a little bit about the prescribing guidelines. And it's one thing to have guidelines, right? But it's another thing to follow the guidelines and to interpret them correctly. And so you each addressed this a little bit, but I'd like to have you talk a little bit more about this. What do you think would rapidly close that information gap in the community? I think we've got a microphone here.
Thanks for the question. It's hard to rapidly close an information gap. But I think some of the interventions that we talked about, like requiring that all primary care providers, really everybody with a DEA license, undergo at least the 8-hour training, which is necessary to understand and treat opioid use disorder in the setting of primary care. That's the buprenorphine training program, is a minimum for starting to meet that information gap. And I also think incentivizing, as I mentioned, the boards, the medical school curricula, and other agencies that accredit us to provide care to require training in medicine would go a long way as well.
Great.
Thanks. And as a primary care provider, I'm shocked that I'm going to say this, but I think it starts with the payment model, and I think that that finance has an awful lot to do with what we do and what we don't do. So sort of picking up on what I said before, I think that payment models that encourage and support us to do the right things are essential, and that's the foundation. Because when the payment models support us to integrate with behavioral health, to provide comprehensive wraparound services in the community, that will then allow us to take the next steps to build that foundation of integration across disciplines. And that will then be followed by educational interventions that train the behavioral health providers and the primary care providers in these new models of care. So I agree, I don't think there's a quick solution, but I think it's a combination of finance and education and training that will allow this to happen. And I think we're moving in that direction, and now a little prompt with some additional funding and some support, I think people will start to come along.
Great. I think David's got a couple comments.
Yeah, and we could learn from our mistakes. I mean, if we understand that the Joint Commission's effort to force every physician who prescribes to patients has to do the pain as the fifth final sign test to promote prescribing, we could have the Joint Commission require that every physician who's prescribing an opioid check the PDMP, and if there's a PDMP concern or risk factor, which can easily be integrated into EHRs with technology, that they have some kind of adaptive response of evaluation or modification of prescribing practice. I mean, this stuff is available in the databases. So this is stuff that can transform practice rapidly across the entire primary care system.
Great, thank you. Other questions from the audience?
Hi. Oh.
Okay.
I got it first. So the most novel thing I think I heard today was the partnership with pharmacy and pharmacists and being able to think creatively about how things are prescribed. Can you talk a little bit about how that partnership came about? Obviously, most people show up at your door with a prescription, but can you talk about how you became partnered with Pathways to Housing and things like that, and how it might be replicated?
Certainly, and it's a shame, but it's all about who you know, right? That's a sad truth. So I knew a friend who was the director at Pathways at the time, and that's how we got it. But if you were to walk through the door of a nonprofit saying you're a pharmacist around the corner, the chances are they will not let you. But it doesn't hurt. I think it's all, I think the only what I would recommend today is to be open-minded, and you as a director or a practitioner at a nonprofit or a facility that provides MAT treatment options or care for patients who are at high risk, have the ability to hear out a pharmacist or to collaborate with a pharmacy, a smaller pharmacy that can do can provide services of this nature. Then why wouldn't you? I mean, there's absolutely no cost involved in it, and that's the beauty of community pharmacy. We're not. It's a shame, but we're not recognized as medical professionals, which means we don't get reimbursed for counseling or services that we provide. Why not take advantage of it? So I think being open-minded is the key to it, and thinking outside the box. If we wait and wait for patients to come through the door, with the reimbursement model the way it is today, as a business owner, I would be broke today. And you do have to think outside the box, recognize where the need is. And I think this is where the need is today. It's a nationally recognized problem, and if you knock on a door saying, I can possibly try reduce opioid-related deaths, I'm not sure why someone would be opposed to hearing that. Thank you.
I want to make a comment on the provider side of that. Patients pay a copayment every time they fill a prescription. So this $3 or $5 copayment, as you mentioned, can be really prohibitive. And that also cramps a provider in trying to prescribe a smaller amount of opioid medication at a time, right? So if I don't think that a patient can really handle having the 30-day supply and I want to dispense them 1 week or 2 weeks at a time, guess what? They don't like that because they have to pay the copay twice. And I love your model in trying to deal with that, but really, in addition, we need copayment reform, right? So that the patient will only have to pay one copayment if they're going to get their medication for weekly.
I completely agree, and that's honestly one of the challenges that we had when we first tried to do it, where your $3, when it gets broken down into 4, it's $12, right? So what we did to overcome that was create a dispensing option out of the pharmacy where we would fill all 4 weeks and dispense it in batches to help with the problem. But see, you go to a CVS, they will not do it, and that's where partnering with smaller pharmacies come into play. Yeah.
Great. I think we've got a question over here on the left.
Yeah, hi. So I split my time in kind of 2 weird spaces between Southeast DC and in the Eastern Panhandle of West Virginia. So I see 2 really different responses. And I'm a little bit taken aback about the lack of conversation around harm reduction, syringe access programs, and how we integrate those models into our response. Because I don't believe that everyone is going to go to an abstinence model, whether that is through medically assisted treatment or through just not using anything or going through a 12-step program. Some people are going to actually continue to use drugs for most of their life. And I think that we also have to figure out how we are going to strategically support them in community as well, particularly around our paraphernalia laws. I really appreciated the comments we had on law enforcement. Thank you, Dr. Gupta, for the work we're doing in West Virginia on harm reduction and syringe access programs. But I think that that has to be a critical piece of how we're thinking about it, and particularly in our pretrial diversion and our pre-release programs. We see very different responses for communities of color in some instances than who are responding to marijuana and responding to crack or other drugs than we are in the opioid crisis. So I'd really like to talk to us a bit about kind of how do we integrate a true community-based model and how we support those community-based programs, not just through federally qualified health centers and large universities and institutions, which now seem to be receiving the bulk of those resources that really need to be on the ground in community.
Gupta.
Thank you for that really important question. for harm reduction, for everybody's information, is sort of a strategy where you accept individuals, understand the challenge of, for a lot of people who, as was spoken about, that this giant monster has taken over their brain and they really can't think and everything else, but they also have this feeling of not, that hostility perhaps from the healthcare system. So there's a lack of trust, the feeling of being judged when they come in. And harm reduction programs, primarily needle exchange, but also inclusive of a lot of other, in terms of comprehensive, from offering of counseling, treatment, family planning, to immunization, screening for communicable diseases, to a whole host of other services, is a strategy that seems to have a lot of evidence behind it. Understanding that, we've developed about 16 state-certified sites across West Virginia to do that. It's controversial, I'll be clear. It's not one that is easily accepted by either communities or elected officials. But I think it's very important to have those in order to avoid, if you remember the Scott County, Indiana situation, where hundreds of HIV cases and as well as hepatitis C happened in a very few period of few months across a very rural population and underserved population. I think when we talk about communities of color, same thing for harm reduction, but also from an incarceration standpoint, we've got to be thinking about, again, diversion programs, alternate drug courts, and the challenge that we also see is within, we talked about a lot about the criminal justice system, but also the judicial system, because we see a lot of challenge in having judges understand this to be a chronic brain disease rather than a choice. We see where cases where judges require moms to be quote-unquote clean from drugs, including MAT, before they can have their kids back. So this is a very difficult problem, not within just law enforcement colleagues, but also within the judiciary across this country, to have them understand. Again, public health has a lot of responsibility there to do, but also to treat this, because often what happens is all of us, many of us, instead of evidence for this particular crisis, we're using the science of, the N of equal to 1. And that one is, my cousin's cousin that went to abstinence base and is still alive. And unfortunately, that doesn't happen with diabetes, hypertension, other things, but we've got a lot of education to do. But harm reduction is a very important, critical strategy that will that needs to be more systematized across the country.
Great, thank you for that question. Very good. A question here?
Hi, my name is Karen Moline, and I work for the International Association of Chiefs of Police. I also work on pre-arrest diversion programs, and I want to say that there are over 500 pre-arrest diversion programs across the country that respond to opioid-related issues, and so that's the good news. And there's law enforcement all over the country, specifically in certain regions of the country, I would say, that do understand this issue and work very collaboratively with behavioral health and their communities and treatment providers, wraparound service providers on this issue. So that's the good news. But I also have a lot of takeaways from this morning, and I've learned an awful lot. And kind of just want to put it out there that we'd like to know how we can partner to bring education to law enforcement. This whole thing about training between law enforcement and drug treatment providers, co-training, cross-training, fascinating. That's a great place to start. We already, every time there's an ICP conference, even the DRE conference, which is drug recognition experts, for the last 2 years we've had panels on pre-arrest diversion and what that means. There's a pathway, we call pre-arrest diversion like different pathways. There's one that specifically responds to OUD, which is called naloxone plus, where after an OD is reversed, they try to coax them into treatment within 24 to 48 hours. We call them victims or clients, are visited by plainclothes police officers in plainclothes with a co-responder, either a peer coach, peer recovery coach, or somebody from the treatment community to try to talk them into treatment, works with the families usually to talk them into treatment. So that's the naloxone plus pathway of pre-arrest diversion. And then there's also, of course, the Gloucester Angel model and outreach models and things like that. So law enforcement is responding to this and in a very collaborative way. So I just wanted to put that out there. And also places like Massachusetts and Rhode Island, those departments of corrections are working on reentry efforts with MAT and using counseling within the jails and in Massachusetts, the prisons, new initiatives, and then providing Vivitrol and then trying to connect to treatment out in the community, working with navigators. And so those things kind of are going on, so that's just kind of the good news. But I do have takeaways and would love to talk to people afterwards.
Great, thank you for those comments. John, do you have anything you want to comment around that?
One of the things I forgot, and that may be what you're alluding to, I was thinking about it up there, I didn't get a chance to talk about it. They call it like a rapid response group, and maybe that's what you mean by that. But what happens is, so if somebody overdoses and they're Narcan back or whatever, and then this group, as she explained, it might be a police officer in plain clothes, maybe a nurse trained in addiction, and a public health person will go and visit that family. And what they find is that these people want to get help, they don't know where to go, which to us, some of that sounds incredible because we deal with this all the time. And so they counsel the family, I think that's what you're talking about, and try and guide them towards treatment and say, here's a phone number you can call. And I think it's a great program. It's worked in Cincinnati or in a suburb, and several other suburbs have taken it on. It sounds like the same thing you're talking about. So that is a very positive thing. And you have to find the right cop to do this. I mean, it's not everybody's in tune to this. So you have to pick somebody who wants to do it and who has that sense of compassion. I can tell you, I had a guy in my unit in Brown County who I would have thought would have been the worst person for this, who volunteered for it, who actually ended up being the best person for it. So anyway.
Great, thank you. Dr. Gupta?
Same way, and I second that, rapid response teams. The only other thing I would add to it, we talked about payment models. One of the things we did in West Virginia is we went and requested and got approved 1115 waiver for Medicaid. And one of the things that waiver allows us to do is, prior to that, if you gave somebody naloxone or Narcan in the field and they decided not to go to the hospital, the EMS unit would not get reimbursed for that. They would lose money, and you can imagine not just the financial, but it gets people upset and all that, because lots of these are volunteer agencies. The waiver allows the billing of that naloxone, even if the people didn't go to ER. But in addition to that, we also then build into it a warm handoff. And so if someone was to get counseled, have a recovery person, or even get an 800 number to call for warm handoff, the EMS person can now bill Medicaid for that service in addition to billing for naloxone. There's an example of how payment can actually drive some connection and getting people.
Great, thank you. Let's go here in the front.
Hi, my name is Jennifer Daly, and I work for the Department of Labor's Chief Evaluation Office. And I was wondering, we've talked a lot about health and law enforcement, but I was wondering if you could talk a little bit about employment, especially with trust in an employer's willingness to hire someone who has a history of opioid use and addiction, and how we can bring employment into the collaborative efforts of health and law enforcement.
Yeah, thank you for that question. We haven't focused as much today on workforce. I'm glad you raised it.
Yeah, that's a really good point. It's a crisis for employers in regions of the country where they can't fill open jobs because pre-employment drug testing can't find anybody who isn't positive for opioids. It sounds preposterous, and it's real. So that's an opportunity to identify individuals. The problem is they're not yet employees, so an employee assistance program isn't typically invoked in that circumstance. And so is it in the employer's interest to try and get those applicants into treatment and offer employment with a condition of effective participation in treatment? It probably is, but I don't know of any models that are doing it. I do know of employee assistance programs, EAPs, that are starting to try and manage employees' recovery better. For instance, Aetna is doing a pilot now that I'm involved in where they're not just doing a referral into community treatment, but they provide ongoing case management services or care management in concert with the community treatment providers because their work may stop when the patient is referred out to the next level of care. But I see the EAP provider continuing to manage the case and also to have a tracking mechanism for the patient where drug testing is actually managed by a contractor of the EAP system, not by the treatment provider. So that can, again, integrate care across these different fragments.
Great, thank you. Let's go back in the back there.
Hi, my name's Sama, and I work at the Pew Charitable Trusts for their Substance Prevention and Treatment Initiative. We partner with states to A, kind of assess their opioid treatment infrastructure, and B, provide recommendations to their state government to expand access to medication-assisted treatment. In a few of the states we've been working in, a few themes that have come up with the provider community is that the kind of default concept for treatment is to go into inpatient, where patients are held between 15 and 30 days, and they're often abstinence-based. And I was wondering what anyone on any panel thought about changing that conception or taking them away from abstinence-based treatment in those settings, or kind of engaging outpatient and primary care providers to provide any outpatient-based treatment there.
Who wants to field that one? Dr. Gupta?
So, so one of the things we happen in West Virginia, as opposed to the national multi-district litigation happening now, is West Virginia was sort of recipient of some settlement dollars. I believe it was 2016, after we filed action against some of those pharmaceutical companies. So we received some funds, and it was exactly the wishes of the legislature in the state to build these facilities for inpatient treatment. But that was the case. So one of the things we did, though, we added a requirement for them to be able to bill Medicaid. And that allowed actually medication-assisted treatment. So we put in that medication-assisted treatment and Medicaid requirement as a precondition to those facilities. Of course, the challenge there is when we talk about long-term facilities, Medicare will not reimburse beyond 30 days, so it becomes a liability for the institution itself to deal with. So we're going to see what happens, but we've given those funds out to build buildings. However, you know, one of the challenges with the SOAR funds that are coming up is, you know, while it's focused on MAT, and we're really focused on MAT in the state, there's this side sort of noise of the absence-based without much data and evidence, and that's a concern because, you know, we don't have a lot of science behind that type of treatment or lack of that treatment. Yet there is a political sort of a constituency there. And it's concerning because I think we're contributing to the overdose deaths each year because of that concept.
Yeah, I have to agree with that. ASAM has two initiatives that are working to counteract that cookie cutter treatment or anti-medication rigid model. And the first is the ASAM criteria software, where states or large counties like Los Angeles County, 10 million population, has 1,500 counselors using the software to assess patients, and then it makes a recommendation of what care the patient needs, which may include opioid medications, as well as the rehabilitation levels of care. And ASAM says that you should be able to get any opioid medication, methadone even, while you're in a residential rehab or a partial hospital program, buprenorphine in any of those levels of care, Vivitrol in any of those levels of care, which is not the standard, unfortunately, in this country. At the end of the assessment, it asks, where did the patient actually go? And if it's in violation or conflict with what ASAM's recommendation is, the state or the county is able to analyze what's the frequency of those discrepancies. And then it can see hotspots of bias that it can address with quality improvement or even contract revisions to try and influence that. And states like Massachusetts, New Hampshire, Florida are starting to plan those efforts. The second initiative is a certification program for ASAM levels of care. In other words, CARF, the Council on Accreditation of Rehabilitation Facilities, is partnering with ASAM, and this was just announced last month, to do a program in a number of states where they'll actually do an accreditation of the treatment program for what level of care does it claim to be, and to what extent does it meet those ASAM criteria. So we do have a process in place for states and counties to start solving the problems that you just described.
Great, thank you. We just have a few minutes left. Question over here.
Hi, my name is Jill Zimmerman. I'm with Econometrica. I want to thank Abt for hosting, Dr. Sparks for inviting me, and the panelists. Y'all have been awesome. In the support law that just was passed, it stated that 13 states' overdose rate is highest for older adults, which was surprising to me. How are we focusing on older adult population and prevention?
Who wants to take that one? Okay, Joanna. Thought you stumped them.
Well, I think the lack of initial response goes to your point that we're not doing enough, right? Addiction has been under-recognized in older adults across the spectrum of care, and it's likely due to prescribing primarily, as well as just the aging of the population. We're going to see more and more older people with addiction, right, in the next 20 years as the population ages and as this epidemic ages. So we do need to do more. There are some movements underfoot to improve, for example, how we prescribe opioids to patients after a knee surgery or hip surgery, or some of these sort of cardinal events that can start an older person on long-term opioids when they weren't previously. But I do think that overall we still have a long way to go. Our geriatrics societies take polypharmacy very seriously, and they have lists of medications which are, safer and less safe for older adults. And because some of the non-opioid pain medications have negative impacts on older adults, like non-steroidal anti-inflammatories, like even Tylenol, those have been sort of less promoted in older adults in favor of opioids for years. Now that's being reversed, but I think there is some of that backtracking that we have to do to sort of re-educate our geriatrics providers and really re-educate everybody about how to think about addiction in older adults and how to manage pain as well as anxiety in safer ways.
Great, thank you. Okay, we're about out of time. Some of our panelists will mill around after the event, so if you didn't get a chance to ask your question, feel free to approach one of them after the event. I wanted to thank everybody for coming. I also wanted to give a big round of applause for our speakers today.